You've already failed your teaching rotation.
Don't
It's
worry,
been fun.
somebody broke it prior to you.
Oh, there it goes. There it
It
goes.
wasn't
Okay.
you, Nick, somebody else broke it.
Jalen.
You guys.
Yeah, I see the back just slides off now.
Yeah, I didn't get to say that.
They beat it up.
We need to buy a new one.
We need to take the best friend, right?
Mhm.
Okay, so we had just talked about the AP in the last one, and so lateral knee is kind of like how you do your lateral ankle, your lateral foot to fit. You always want to like, it's gonna go out, kind of like, you know, like that. It's kind of how you do all your laterals on your lower extremities. But the important part on here is that you gotta flex it a bit. You don't want to over flex it because then you close the knee joint. And in the later slides, it'll tell you the exact degree that you want to close it. And also, if the patient can, Mr. Donahue taught me this, it's better, like when they're laying down, they're laying supine, they bring their leg out, and if they're flexible enough, you can bring their unaffected leg over.
Cross
the
their
affected. Yeah. That makes it, because sometimes there's rotation and that helps with the rotation.
In fact, in my experience, that bring the leg over method that he's talking about almost always gives you a more optimal view. That's like what I would call the gold star method of getting good, beautiful lateral knees. Because lateral knees can be challenging in that they'll often look rotated with the condyles. But when you bring that leg over, it almost always puts the leg in a perfect lateral for you. That combined with that angulation nails it almost every time. Just my personal recommendation. I don't like that picture. I don't like doing it that way. I like to bring the leg over, like he's talking about.
It's true. But a lot of techs will, like from my experience, they just like fast, like, no, don't worry about that. They just want you to go. But you know, if you have your own time, like try it out. I like doing it the way Donahue does it also.
I have a quick question, but it might sound stupid. I should have asked it like
No
maybe a
stupid
long
questions.
time ago. But what's the point of like having like yesterday I was in lab and I was doing a lateral calcaneus. So I had I think it was a 8x12. What's the really point of like centering the calcaneus with the IR? Like if it why can I
That's
just
a
put it
really
on
good
there?
question.
And then like if the light field's already on it, why do I need to center it with the IR?
That's a really good question. You should be able to answer that. Have y'all not talked about that in PRE?
Yeah, I was about to.
Period.
Yeah,
I
it has
haven't talked about
something
that
to
in
do.
PRE.
It's
You're leaving?
No, I'm.
You haven't answered the question yet. Nick, why don't you give her the explanation?
I'm not even
You
sure.
perked up when I said that, so.
This is what I'm thinking. I'm not sure if it's right, but you know, you center it because you always want to center at what you're looking for, right? So you're looking for the calcaneus, so you put it. I think it's like an inch below the calcaneus, right?
Yeah.
She's talking about centering to the cassette itself.
Yeah. Well, I'm just using this as.
Oh, go ahead,
So,
sorry.
You said that's what you're looking for, so you want the central ray to pass exactly where you're at because that'll let you collimate more. Because if you just have the whole thing and then you're not lined up, you have to get more of the image in. And also, I forgot what Mr. Fung said.
So just to give you a more simplified, I won't go into all the technical details. I won't throw too many big words at you, but the simplest explanation is on a CR cassette like this, they're very sensitive to not centering the part on the cassette. So if I put a part down here, spatial and contrast resolution is going to suffer greatly versus if I put it in the middle where the distribution of rays is going to be more even. It's going to throw everything off quality-wise if I do it down here. Now, with the DR cassettes, the new technology, they're getting so advanced that it's not really mattering where you put it. It still looks good. But for CRs especially, because they're so highly sensitive to X-rays, if I am off-center, the overall quality is going to suffer because of the way the rays are going to scatter and shoot all over the cassette. So think for example, if I have a hand right here, the scatter occurs, the rays are kind of evenly distributed around it. If I have it down here, they're all going to go like this, like bleh, all over the place, like vomit all over your cassette. To put it in layman's terms, it's going to bring the quality down. It's going to be more pixely, less smooth. It's just going to get an uglier image. So really, it has a big effect on image quality, mostly, once you're using DR, which has kind of mitigated that issue.
I think they're about to talk about that in PRE right now. like
Mhm.
spatial resolution, pixel matrix, and stuff like that.
I have a question on this one, bro.
Yeah.
Like when you cross the unaffected leg over too, does it help when you like rotate the hips back too to get the epicondyles parallel?
Well,
I mean superimposed, like when you get what I'm saying?
yeah, I get what you're
Does that
saying.
help?
So like this, and then rotate
Yeah,
it.
kind of help rotate the hips so they
Yeah,
can
I mean, as long as it's not covering the leg, and
Mhm.
what I like to do is I like to, cause you can feel them, right?
Mhm.
So you can kind of like, oh, it's kind of like tilted, and you can bring it up a little bit. But it's just this helps it, cause sometimes, most of the time, your face is kind of elevated a bit.
Mhm.
So when they bring their leg over,
It kind of moves it. Okay.
yeah. But you also gotta be careful you don't go too much
Mhm.
the other way. And I'll show you in the other slides what like that would look like.
Not to embarrass you, but I already got someone send me a LinkedIn connection. There you go. You're doing it right.
That's funny.
I just accepted you.
But yeah, you would have to rotate the hips to get that leg over
Yeah.
there, for sure. Okay, so again, like I said, you want to bend the knee, and this is a 20 to 30 degree flexion. This will give you a maximum volume, a joint, like the joint will be, this is the most optimal to see the joint when you're doing the lateral knee.
Nice and open versus closed, like he was talking about.
Yeah.
They'll open it up best for you.
And then again, you don't want to keep it straight out, because then it'll close, and if you flex too far, it'll also be closed. That's like the sweet spot. And then right here, just a disclaimer, if it's, you have a fractured patella, you kind of like what's tolerable to the patient, I'd say, you know, so like no more than 10 degrees, 'cause, you know, they're gonna be in pain with their patella fracture. Okay, and then like how I
Expound on
said,
that second bullet point.
Yeah.
Explain that to them. Those,
Right.
I mean, those next two, those are big ones right there.
yes. So this, all we've been talking about before is for literally these 2 bullet points. This is like some of the most important thing when you're getting your lateral, is making sure your femoral epicondyles are perpendicular and superimposed to each other on the IR. And like I said, bringing that leg over and feeling them and making sure they're lined up will give you that. Obviously, the patella will be perpendicular also if your condyles are superimposed. Okay. We have the, so kind of like on the AP knee, I think that one was 3 to 5 degrees cephalic. This one is going to be 5 to 7 degrees cephalic. And you want to center your ray 1 inch below the medial epicondyle or inferior.
And you'll see a range there, and for me, in my experience, you can almost always go with 5. If you do 5 combined with bringing the leg over, it's almost gonna get it perfect every time, just in my experience. So you have the range, but I stick with 5 combined with bringing the leg over. I get it almost every single time. See that beautiful image down there? Man, that's like something you hang on your wall right there. I mean, that's just so pretty. You want those beautiful superimposed condyles. Nice, pretty space there. If any of this is closed, any of this is rotated, it's trash. You want to look like this. But a lot of techs like to sit in trash. Don't sit in trash.
It's a
It's
lot
so
harder
pretty.
to get than you
It's,
think.
it can be,
Yeah.
but do my method, you're almost 9 times out of 10 gonna get it very close to that.
I'm sorry. We use the 5 to 7 angle, degree angle to account for the curvature of the femur.
Yes, we do.
So this bottom part right here, the angle helps with this, what is that aspect of the femur?
Remember how the femur kind of sits tilted
Yeah.
in the body? It helps mitigate that tilt and superimpose those condyles better for you.
Yeah. And in the future slides, it explains a little bit better from what I saw. So these are the structures that are shown in your lateral, the distal part of the femur, which is right here, patella, your knee joint, which is open right here, you can see it's open. And then proximal ends of the tip is right here. And again, like the main things for the lateral, I'll say one more time, superimposed epicondyles right here, and then the joint space open with the patella also lateral.
Was that on the previous slide?
The
What's up?
previous.
Oh yeah, the previous one. Do you want me to go back? Just like the bottom three. Good? So, this is also, this would be a what projection? Kind of says it up there, right?
Lateral.
Yeah.
Medial lateral.
Medial lateral. Okay, so this is like the optimal image criteria that you want. So obviously, always collimation and have your correct marker, not the digital one, even though it shows it right there. And that's for every single image. So, like again, knee flex 20 to 30 degrees, I think. Is that more than 20 degrees?
That's about 20 okay.
So moral condyle superimposed right here. So this is important right here. This is what I was talking about earlier. So over rotation, so anterior surface of medial condyles closer to patella. So if you're over rotated, the medial condyle will be closer to the patella, right? So this condyle will be closer to your patella. So it's kind of going in to the IR. And then under rotation, anterior surface of medial condyle is further from the patella, so it will be curving out, right? Insufficient CR angle. This is also what else, this is why you angle, because the inferior surface of the medial condyle caudal to lateral condyle results from, yeah, I read that earlier too. But basically what it's saying is the inferior surface of the medial condyle. So, cause you know you have your medial and your lateral, right? Medial lateral. So, this surface of the bottom part of it,
Like coming down like this.
yeah, you'll see. So I don't know if you guys can see this little like shade right here. You see how it's like more dense and it's like a slight sliver that's like less dense. It'll look like that, but on the bottom, and it'll be like way bigger. I think there's a picture in here that'll show it. And then if it's too much, it'll still look the same, but it's the other way this time. It's the lateral one that's covering the medial.
So these 4 bullet points here, guys, I want y'all to put take a picture of that, whatever you gotta do, write it down, put a star on that, put it in your personal parking lot. So we're gonna come back to that whenever you're at his point next year
He will ask.
for your last registry review class. You're gonna have to be able to look at an image and identify what's wrong with it based on those 4 bullet points. We're not gonna do that yet because we're not there yet. We're gonna learn more about that when we talk about like image critiques in your image critique class. But you will have to identify why it looks rotated based on those 4 bullet points there. So it's an excellent slide. Keep on your parking lot until we come back to that. We will revisit that at a later date.
And Joe asked like, how do you fix this?
How do you fix it, right?
Oh, real quick. So, the rotation, this is how I kind of learned it. For rotation, it affects like this posterior and anterior side, like this part, and then your angle affects the bottom part. Is that correct? Right. Yeah. So just so you guys are more familiar with that. So again, the fibula should be slightly superimposed in a good lateral. And if it's over rotated, it'll be more separated. And if it's under rotated, it'll be more superimposed. So this gap will either be bigger or smaller depending on if it's over rotated or under rotated.
Yeah, basically you would see the apex being superimposed as well if it was under rotated. You just want kind of like the top of the head there, barely superimposed. You can see in that picture. That's your ideal optimal view for a lateral.
And your patella's lateral, you can see, even the patella, you can tell sometimes when it's over rotated. You'll see like different like shades right here. You can see it like kind of turning, but this one looks pretty good. the joint space is open. You can tell it's completely open. Space. Okay, this one. This is the one I didn't understand. This one.
So you just want this area here to be as open as possible. It's obviously not gonna be completely open
Okay.
because the intercondylar eminence is slightly superimposed. But basically, you just want that slight little joint gap there. If you see that condyle dipping way down, what was that indicative of that we just talked about? Something's off with the what? The angle. The angle's wrong, if that's dipping down. If they're nicely superimposed, and get that nice space there, that's ideal, that's what we want right there.
It wouldn't be.
So as you see your nice little plateau, we talked about plateaus, got your nice flat plateau that you can see right there.
And then become familiar with this term, guys. Bony tubercular detail and soft tissue. So, did you saw what that was, Mr.
They know what that is.
Okay. So yeah, just remember that word because you're gonna need it in some time. And then, so you can see the fine details. Not too much on this one.
It's
And then-
better on the.
Yeah, on the bottom. Yeah. And then the soft tissue you can see right here. Okay.
Ah, it's a great example.
Yep. Yep. So what is this one, guys? What do you guys think this is? What's like wrong with it? You remember the fibula? Also, you can tell that
It's
it's
not
rotated.
Too rotated.
Less rotated.
Right, I said two, she said over, you said under.
It's over rotated.
Too much.
Go back, let them look at the slide again.
Okay.
There's one real easy way to tell. Well,
Oh, yeah.
go right there.
Right here,
Look at those
guys.
two little points right there. Now go back to the image. There's too much superimposition on the fibula,
So it's
so it's
under rotated.
under rotated.
Really?
Now, I know a lot of y'all were looking here, and yes, you can,
Yeah.
because we talked about that medial condyle changing position. But because they're superimposed, it's a little hard to tell which one's the lateral, which one's the medial. So it's a little bit easier if you focus on the fibula for the under rotation. If this was way out here, it'd be over rotated. But because it's almost completely superimposed at the head, that's under rotated. Now, we don't see an example of the angle issue where it's dipping down. If that condyle is dipping down, it tells us that our angulation is off, or not angled at all. But y'all see what I'm talking about? Under rotated, whenever that fibular head's almost completely covered.
And you can see
Over
right
rotated,
here.
it would have been more separated over here. That's pretty close to a good image that we see right here. That's pretty optimal on the right, aside from the marker issue.
Combination's pretty good.
Combination's good, you know, we got these little growths, a little bone spur there, by the way. You can get bone spurs on your knee too, like that. But do y'all see what I'm talking about? You see what we're talking about with the under rotation here? Like I said, we're gonna revisit that more so in the summertime, but keep that in your parking lot. Here's a way to identify that.
If I'm correct, so if let's say this one was over rotated, the femur would look similar as it does here, but this would be farther apart, right? So that's why it's kind of hard to tell based off the femoral heads, because they look similar if it's under or over, and one of the big tells is in the fibula.
By the way, what's that right there?
The sesamoid.
See the little knee sesamoid? Get those two.
We're rotating laterally.
So it's under. So that one right here would look like this.
Is
You
this
would
the
have to
same
push it
patient?
back down.
Yeah, that's what I was thinking. Thank you.
That's what's gonna happen most often if you do that method where you don't put the leg over.
Yeah, that's why you put the leg over.
That's why I always say it's better to put the leg over. You get that more true lateral position naturally with the body versus relaxing the leg. More often than not, that left image is what your x-ray is gonna look like. So it's not worth even risking it personally.
Mr. Donahue?
Yeah.
Is this the same patient? Like
Yes,
they
it
just
is.
messed up or they had to shoot 2 repeats?
Yes.
And I don't know if you guys have, I'm sure you guys in clinics have seen these, right?
Mm-hmm.
And I'm pretty sure you guys have seen some that look kind of like messed up like this.
Mm-hmm.
That Tech just sends them anyways.
Mm-hmm. Keep going next.
Next.
I wouldn't want to put my name on that. I wouldn't want my initials on that.
And it feels so good when you get one of these, and you're like, oh yeah, I get like this. I like getting these. So APD weight bearing. So it's kind of like the AP knee, but you're just putting weight. You're not doing it on the table. You're doing it in front of the wall bookie. It's like bending with the back against a vertical grip for your IR. So center your knees to the IR. So you're gonna have them stand right here in front of the IR, kind of how they have in the picture here. And then your central ray is going to enter half an inch below the apex of the patella. What? That's the next. Oh yeah, right there. Half an inch below the patellar apices. And then in between both legs. In between both knees. And then make sure their feet are like they have good balance. They're not gonna fall on you.
Yeah, third bullet point is very important because naturally, think about yourself with your knees hurting. You're probably not gonna wanna put all your weight on that knee, so you're gonna put all your weight on your good leg. But you gotta ensure they're putting equal weight on both those feet, otherwise you're not gonna get the weight bearing to you of both. Actually, let's let them take their first break. We talked so much in the first part, we're already at our first break time, it's 9 o'clock. Take 15 minutes, guys, come right back at 9:15.